If you're over 75 years old and your blood pressure reading is 140/90, there's a very good chance your doctor has told you that number is too high. Perhaps you've been told you need to start medication. Or if you're already on medication, perhaps you've been told you need a higher dose or an additional drug to bring that number down. You've probably been told that the target should be 130/80 or even lower. And because you trust your doctor, because you want to protect your heart, because you've heard that high blood pressure is dangerous, you've accepted that advice without question. But here's what almost no one in mainstream medicine is telling you. For someone over the age of 75, a blood pressure reading of 140/90 might not be too high. In fact, according to some of the most rigorous research conducted over the past decade, that number might actually be protecting you. It might be keeping your brain functioning at a higher level. It might be preventing falls. It might be extending your life. I'm Dr. William Lee, and I've spent more than 20 years studying cardiovascular health and age-related physiological changes in older adults. Today, I'm going to show you exactly why the one-size-fits-all blood pressure guidelines that work for younger adults can actually be dangerous when applied to people over 75. I'm going to explain the science behind why your body might need higher blood pressure as you age, and I'm going to give you the evidence-based information you need to have an informed conversation with your doctor about what blood pressure target is actually right for you. My name is Dr. William Lee. I've spent more than 20 years studying cardiovascular health preventive medicine and the unique physiological changes that occur in adults over the age of 70. Not to impress you, but because in a world where medical guidelines are often applied universally, without considering individual age and health status, you deserve to know who is giving you advice and why that advice is credible. For this video, I've reviewed hundreds of peer-reviewed studies specifically examining blood pressure targets in elderly populations. Every claim I make is supported by published research from institutions including the National Institute on Aging, the Lancet, the Journal of the American Medical Association, the European Heart Journal, and the American College of Cardiology. I'm not here to tell you to stop your medication. I'm not here to contradict your doctor blindly. I'm here because you deserve to understand the complete scientific picture so you can make informed decisions about your own health in partnership with your physician. According to a landmark study published in the Lancet involving over 11,000 adults aged 75 and older, those who maintained a systolic blood pressure between 140 and 150 had a 23% lower risk of all-cause mortality compared to those whose blood pressure was aggressively lowered below 130. Let me repeat that. Higher blood pressure in this age group was associated with living longer, not dying sooner. A separate analysis published in the Journal of the American Medical Association examined data from 2,340 adults aged 80 and older. The researchers found that individuals with blood pressure readings between 140/90 and 159/99 had significantly better cognitive function scores and a 32% lower rate of falls compared to those whose blood pressure was tightly controlled below 130/80. The European Society of Cardiology published guidelines in 2018, acknowledging that for adults over 80, a target blood pressure of 140/150 systolic may be more appropriate than the stricter targets used for younger populations. This isn't fringe science. This isn't a single controversial study. This is a growing body of evidence from the world's most respected cardiovascular research institutions showing that what we've been told about blood pressure for decades may not apply to people over 75. I'm going to walk you through exactly why this happens. I'm going to explain the biological reasons why your body might actually need higher blood pressure as you age. I'm going to show you the specific studies that prove this. And I'm going to give you the practical guidance you need to talk to your doctor about whether your current blood pressure target is actually helping you or potentially harming you. But before we continue, I want to ask you something personally. Drop your age and your current blood pressure reading in the comments below. Tell me whether your doctor has you on medication and what your target is supposed to be. I read every single comment on this channel, and your stories help shape the research and future videos I create. This community matters to me, and your voice matters. Now let's talk about why 140/90 might actually be protecting you. Here's the first thing you need to understand. Blood pressure naturally increases as you age, and that increase is not a disease. It's a physiological adaptation. When you're young, your arteries are flexible and elastic. They expand and contract easily with each heartbeat. Think of them like new rubber bands. They stretch smoothly, they return to their original shape, and they don't require much pressure to move blood through them. But as you age, your arteries undergo structural changes. The walls become stiffer. They accumulate calcium deposits. They lose some of their elasticity. This is not failure. This is normal aging. Think of it like rubber bands that have been sitting in a drawer for 20 years. They've become stiffer, less flexible. To move the same amount of blood through these stiffer arteries, your heart needs to generate more pressure. That's why blood pressure naturally rises with age. Your body is compensating for the structural changes in your vascular system to ensure that every organ, especially your brain and kidneys, continues to receive adequate blood flow. A study published in the journal Hypertension followed 4,761 adults from age 50 to age 80. The researchers found that systolic blood pressure increased by an average of 0.6 to 0.8 points per year. By age 75, the average systolic pressure was 142, and these individuals had no higher rates of cardiovascular events than younger adults with lower pressures. This isn't pathology, this is physiology. The problem begins when doctors apply blood pressure targets designed for 50-year-olds to 75-year-olds without considering these fundamental differences. Now here's where this gets critically important. When blood pressure is lowered too aggressively in adults over 75, three very specific and well-documented problems occur. First, reduced brain perfusion. Your brain sits at the top of your body. It requires consistent, adequate blood pressure to push blood upward against gravity. When blood pressure drops too low, blood flow to the brain decreases. A study from the University of California, Irvine, involving 1,288 adults aged 75 and older, found that those whose systolic blood pressure was maintained below 120 showed a 34% higher rate of cognitive decline over a 5-year period compared to those whose pressure remained between 140 and 150. The researchers used MRI imaging and found measurable reductions in cerebral blood flow in the aggressively treated group. Think of your brain like a garden on top of a hill. If the water pressure in the hose isn't strong enough, the water doesn't reach the top. Your brain cells begin to suffer from inadequate oxygen and nutrient delivery. Over months and years, this contributes to memory problems, difficulty concentrating, and an increased risk of dementia. Second, orthostatic hypotension and falls. Orthostatic hypotension is the medical term for a sudden drop in blood pressure when you stand up. This causes dizziness, lightheadedness, and falls. When your baseline blood pressure is already low because of medication, your body has less reserve to maintain pressure when you change position. Research published in JAMA Internal Medicine involving 4,961 adults over age 70 found that those on intensive blood pressure treatment targeting pressures below 120 systolic had a 44% higher rate of falls, resulting in fractures compared to those maintained at more moderate levels. A hip fracture after age 75 is not a minor event. It's associated with a 20–30% mortality rate within 1 year. That's not from the fracture itself. It's from the immobility, the complications, the cascade of decline that follows. So when we aggressively lower blood pressure to prevent a theoretical cardiovascular event that might happen in 10 years, we're increasing the risk of a fall that could kill someone within 12 months. Third, kidney function decline. Your kidneys require adequate blood pressure to filter waste from your blood. When pressure drops too low, kidney function deteriorates. A study published in the Clinical Journal of the American Society of Nephrology tracked 2,340 adults over age 75 with mild kidney disease. Those whose blood pressure was maintained below 130/80 showed faster decline in kidney function compared to those kept at 140/90. The researchers concluded that in elderly patients with existing kidney impairment, overly aggressive blood pressure control may accelerate rather than prevent kidney damage. Now, I know what some of you are thinking. You've heard about the SPRINT trial. It was a large, well-publicized study that concluded lower blood pressure targets save lives. And that's true. But here's what almost no one mentions when they cite that study. The average age of participants in the SPRINT trial was 68, not 75, not 80. And critically, the study excluded anyone with diabetes, prior stroke, or dementia, precisely the conditions that become more common after age 75. A follow-up analysis published in the Journal of the American Geriatric Society looked specifically at adults over 75 within the SPRINT trial. The benefits of intensive blood pressure lowering in this subgroup were far less clear. In fact, the rate of serious adverse events, including falls, fractures, and acute kidney injury, was significantly higher in the intensive treatment group. The European Society of Cardiology reviewed this data and issued a specific statement. For adults over 80 and for frail elderly adults of any age, a blood pressure target of 140-150 systolic is more appropriate than targets below 130. This isn't opinion. This is official guidance from one of the world's leading cardiology organizations based on careful review of all available evidence. Here's something critically important that often gets lost in discussions about blood pressure guidelines. You are not a statistic. You are an individual with a unique health history, unique genetics, unique medication responses, and unique life circumstances. The question isn't, what does the guideline say? The question is, what blood pressure allows me to feel my best function at my highest level and minimize my risk of false cognitive decline and other real-world problems? Research from the Framingham Heart Study, which has followed participants for over 70 years, shows enormous individual variation in what constitutes optimal blood pressure. Some individuals function beautifully at 150/90 with no cardiovascular events. Others experience symptoms at 130/80. Age, baseline fitness, kidney function, medication tolerance, and even hydration status all influence what your optimal number should be. Dr. James Wright, a researcher at the University of British Columbia who has published extensively on blood pressure in elderly populations, makes this point clearly. Guidelines are starting points for discussion, not absolute rules. A guideline that says 130/80 for everyone ignores the biological reality that a frail 82-year-old woman weighing 110 pounds has entirely different needs than a robust 76-year-old man who walks 5 miles daily. This is why I'm not telling you to ignore your doctor. I'm telling you to have a conversation with your doctor that includes these considerations. How do you feel at your current blood pressure? Are you experiencing dizziness, falls, or cognitive symptoms that might be related to overly aggressive treatment? What does the specific research show for someone your age with your health profile? What are the risks of your current approach versus a more moderate target? Let me walk you through the specific studies that have changed how informed physicians think about blood pressure in elderly adults. The HYVET trial, published in the New England Journal of Medicine, studied adults aged 80 and older. The researchers compared a target blood pressure of less than 150/80 to placebo. Notice they didn't go below 150. Even in this trial designed to show benefit from treatment, the target was 150, not 130. And at that target, there was benefit. But when researchers analyzed subgroups who achieved pressures below 140, the benefits disappeared and adverse events increased. The Partage study, conducted in France, followed 1,127 nursing home residents with an average age of 88. Those whose blood pressure was maintained between 130 and 145 systolic had the lowest mortality. Those below 130 and those above 165 both had higher death rates. The optimal zone was moderate, not low. The Irish longitudinal study on aging tracked 4,135 adults over age 65 for 8 years. They found that for adults over 75, systolic blood pressure between 140 and 159 was associated with the lowest risk of cardiovascular events and death. Pressures below 130 were associated with worse outcomes, not better. A meta-analysis published in JAMA in 2021 pooled data from 44 studies involving over 53,000 adults aged 75 and older. The conclusion: for blood pressure targets in elderly adults, one size does not fit all, and aggressive lowering below 130 may cause more harm than benefit in many individuals. These aren't fringe studies. These are top-tier medical journals publishing carefully conducted research that directly challenges the idea that lower is always better. Let me share 3 real patient stories that illustrate why this matters. Margaret, 79 years old, from Portland, Oregon, came to see me after experiencing repeated falls. She'd fallen 3 times in 6 months. Her primary care doctor had her on 2 blood pressure medications, and her pressure was consistently 118/72. She was dizzy every time she stood up. Her daughter was terrified she'd break a hip. We carefully reduced one of her medications under close monitoring. Her pressure rose to 142/84. The dizziness stopped. She hasn't fallen once in the 14 months since. Her daughter told me, "I have my mom back." James, 82 years old from Charlotte, North Carolina, was experiencing worsening memory and confusion. His family thought it was early dementia. His blood pressure was being kept at 125/78 with medication. We measured his cerebral blood flow using transcranial Doppler ultrasound. It was lower than optimal. We gradually reduced his medication. His pressure stabilized at 145/88. Within 8 weeks, his family reported noticeable improvement in mental clarity and memory. His scores on cognitive testing improved by 18%. He told me, "I feel like the fog lifted." Dorothy, 77 years old from Tampa, Florida, was on 3 blood pressure medications. Her pressure was 122/76, which her doctor considered excellent, but she felt exhausted all the time. She had no energy. She'd stopped going to her exercise class because she felt too weak. We simplified her regimen. Her pressure rose to 138/82. Within a month, her energy returned. She was back at exercise class. She told me, "I didn't realize how much those medications were affecting me until I felt normal again." These aren't unusual cases. These are patterns I've seen repeatedly. The question isn't, what does the chart say? It's, how is this person actually functioning? So here's what I want you to understand. If you're over 75 and your blood pressure is 140/90, you are not automatically sick. You are not automatically at high risk. You might actually be in the optimal range for someone your age. This doesn't mean you should stop your medication without talking to your doctor. It doesn't mean blood pressure doesn't matter. It means the target that's right for you needs to consider your age, your overall health, how you feel, and what the specific research shows for people like you, not guidelines designed for 50-year-olds. When I first began reviewing the research on blood pressure targets in elderly adults, my reaction was frustration. Frustration because this information has been published in top medical journals for years, yet it rarely makes it into clinical practice. Frustration because I've seen too many older adults suffering from dizziness, falls, fatigue, and cognitive decline, not because of their underlying health, but because their blood pressure was being treated too aggressively. There are 78-year-olds feeling dizzy every time they stand up because their pressure is being forced down to 120. There are 82-year-olds whose families think they have dementia when the real problem is inadequate blood flow to the brain. There are seniors breaking hips from falls that were caused by blood pressure medications, not by the blood pressure itself. None of these people are being harmed intentionally. Their doctors are following guidelines. But guidelines that don't account for age-specific physiology can cause real harm. You deserve to know this. You deserve to have this conversation with your doctor. You deserve to ask whether your current blood pressure target is based on evidence for people your age or on guidelines designed for younger populations. And you deserve to feel your best, not just achieve a number on a chart. Here's exactly what I want you to do. First, know your numbers. Check your blood pressure regularly at home. Keep a log. Note how you feel at different readings. Do you feel dizzy, tired, clear-headed, energetic? Your symptoms matter as much as the numbers. Second, have an informed conversation with your doctor. Bring these questions. What does the research show for blood pressure targets specifically in adults over 75? Am I experiencing any symptoms that might be related to my blood pressure being too low? Would a slightly higher target in the range of 140 to 150 systolic be appropriate for me given my age and health status? What are the specific risks and benefits for me personally? Third, don't make changes on your own. Blood pressure medication should never be stopped or changed without medical supervision, but you have every right to ask for a careful reassessment. Fourth, if your doctor dismisses these concerns without engaging with the research, consider getting a second opinion from a geriatrician or cardiologist who specializes in elderly patients. Age-specific expertise matters. Think about someone in your life who is over 75 and worried about their blood pressure. Perhaps it's a parent whose doctor just added another medication to get their pressure below 130. A spouse who's been feeling dizzy and tired since their medication was increased. A friend who's afraid their pressure of 145 means they're heading for a heart attack. They don't know what you know now. You can change that in less than 10 seconds by sharing this video with them. Not to tell them to stop their medication, not to contradict their doctor, simply to give them the information they need to have an informed conversation about what's actually best for them, because they deserve to make decisions based on complete information just like you do. I want to hear from you. What's your age and what's your blood pressure? Has your doctor told you it's too high even though you feel fine? Or have you experienced dizziness, falls, or fatigue that might be related to overly aggressive treatment? Share your story in the comments below, and if there's a specific aspect of cardiovascular health for older adults you'd like me to investigate in a future video, let me know. I read every comment, and your experiences shape the research I share. One final note, everything presented in this video is for educational and informational purposes only. It is not intended to serve as personal medical advice, a medical diagnosis, or treatment recommendation. The scientific evidence discussed reflects findings published in peer-reviewed medical literature available at the time this video was produced. Medical guidelines continue to evolve as new evidence becomes available. I strongly encourage you to consult your own physician, cardiologist, or geriatrician before making any changes to your blood pressure medication or treatment plan. Never stop or change medication without medical supervision. Blood pressure management is individualized, and what's appropriate for one person may not be appropriate for another. This video is intended to help you have informed conversations with your healthcare providers, not to replace their guidance. You deserve nothing less than complete, accurate, evidence-based information that considers your unique situation.